Often hear about infertility as it relates to women. It's always our uterus that everyone is talking about. And certainly, if there's issues having children, everyone automatically assumes that maybe the woman is at fault. So it's always good to have conversations that we don't normally hear in this space. Our very next speaker is Dr. William Derval Aiken, a medical doctor and consultant urologist at the University Hospital of the West Indies, a lecturer in surgery at the University of the West Indies, MBBS from UA 1989. He's a fellow of the Royal College of Surgeons of Edinburgh. He has a DM in urology, postgraduate diploma in epidemiology, MSc epidemiology, urology, and he's a fellow of the American College of Surgeons. He's the author of more than 47 articles in peer-reviewed journals and several other publications. He is currently a volunteer doctor at the Jamaica Cancer Society's prostate cancer, and his topic is the changing face of men's sexual health, male infertility, and erectile dysfunction. Please help me welcome Dr. William Aiken.
Thank you, Terry Carell. Thank you for that wonderful introduction. Good morning. It's such a pleasure to be here, and I want to thank MDS for inviting me to be part of this empowered presentation and empower persons with knowledge that you can make a difference in people's life. So this morning, we're going to be looking at a very important topic, in fact, two topics, male infertility and erectile dysfunction. Now, let me just say right up that erectile dysfunction used to be called impotence, but we no longer use that term because it's a pejorative term. It's a demeaning term, and so we no longer use the term impotence. It's strictly erectile dysfunction. So I have no conflicts of interest to declare, and our objectives for today, at the end of the presentation, the audience should be able to define male infertility, state what percentage of times a male factor is present in couples with infertility, discuss the causes of male infertility, and look at the percentage of times that couples have this problem, discuss the treatment options. Where erectile dysfunction is concerned, we're going to define it so everybody is clear what constitutes erectile dysfunction. We're going to look at risk factors, we're going to look at causes and the prevalence, how common is it in the community, and of course, we're going to look at treatment options. So let's get right into the meat of the presentation. So what exactly is infertility? So if you have a couple, what we call a non-contracepting couple, or a couple who is having unprotected sexual intercourse, and one whole year passes and they have not achieved conception, then by definition, that couple is experiencing infertility. Now, in 25% of cases, there is a sole male factor. So in 25% of cases, there is a single male factor involved. But in another 25% of cases, there is a contributing male factor. So in fact, together, where you have the sole factors and the contributing male factors, overall, in 50% of cases, a male factor is responsible for couples experiencing infertility. And this is very important to understand because a lot of times, women are the ones who go to the gynecologist with this problem, and sometimes they are the ones who are investigated and the man is investigated later. But the astute gynecologist will investigate both the male and the female simultaneously, recognizing that in 50% of cases, the male factor is actually responsible. Now, there are two types of male infertility, what is called primary male infertility and secondary male infertility. In primary male infertility, the male has never impregnated a woman, whether his current partner or a previous partner. Secondary male infertility is a situation in where the man has impregnated a woman on a prior occasion. It doesn't matter if it's a current partner, and it doesn't matter if the woman carried that pregnancy to completion. So it's very important to make this distinction because primary male infertility generally has a worse prognosis than secondary male infertility, and usually there are significant underlying problems in a man who has never impregnated a woman. So secondary causes are due to things like a varicocele, which is similar to varicose veins occurring in the veins that drain the testicle. You all know varicose veins that affect the legs. Well, if you think of varicose veins affecting the veins that actually drain the testicle, this prevents the testicle from keeping cool, and the testicle is kept warmer than usual, and this affects infertility. So this is a very common cause of secondary male infertility, as well as genital tract infections. Primary male infertility, you generally have congenital problems, and it usually indicates severe sperm impairment, or sperm quality is significantly impaired. Now, very important, the duration or the length of time that a man has never impregnated a woman, what we call the period of involuntary infertility, is a significant risk, because the longer that period, the worse the prognosis. We mentioned, or perhaps we didn't, that 85% of couples by 1 year having unprotected sex will achieve conception. So that means 15% won't. Now, what happens to that 15%? Well, a significant proportion of that 15%, if they continue having unprotected intercourse, will actually conceive naturally over time. So you can well imagine if somebody has been having unprotected sex for a long period, years, and no pregnancy has been achieved, then that usually indicates a significant and severe underlying problem. So the duration of involuntary infertility is very important to ascertain when we're taking a history from a patient. Now, what's the goal of evaluating patients with infertility, and specifically male infertility? Well, we want to identify underlying, potentially correctable conditions. We want to identify irreversible conditions that are amenable to assisted reproductive techniques using the sperm of the male partner. We also want to identify irreversible conditions that are not amenable to assisted reproductive techniques, for which donor insemination, where you use the sperm of an unidentified donor, or adoption is a possible option. And then we also want to identify life or health-threatening conditions that affect fertility and which require urgent intervention. And finally, we want to look for any genetic or chromosomal abnormalities that may affect the health of the offspring if assisted reproductive techniques are employed. Now, we're not going to be able to go through all of these in a short time, because remember, we're going to be talking about erectile dysfunction as well. But these are, in fact, the goals of evaluating the patient with male infertility. Now, I'm going to just look at some causes of male infertility very briefly. This is by no means an exhaustive list. If we were to look at an exhaustive list, it would take the entire presentation. But these are the most common causes. We have congenital causes, such as absence of the vas deferens, a tube that carries sperm from the testicle to the urinary tract. We have developmental abnormalities, for example, an undescended testicle, where the seed or the testicle has not descended from the abdominal cavity into the scrotum. We have acquired urogenital causes, such as ejaculatory duct obstruction, very commonly seen in men who have gonorrhea and gonococcal urethritis. We have retrograde ejaculation, where instead of the semen coming out in a pulsatile, projectile manner, it goes back into the bladder. So long-standing diabetics have this problem, may have this problem, and men who have had surgical procedures on the bladder neck, or they've suffered trauma, such as pelvic trauma in motor vehicle accidents, these men may have retrograde ejaculation. Then urogenital tract infections. Mumps orchitis is a big one. So round about the teenage years, if a young man gets mumps, it can significantly cause inflammation of the testicles and can make him sterile. So that's a big one. If you're going to get mumps, get it when you're a baby. Try not to get it when you are a young man or adult. And then I mentioned earlier gonococcal urethritis, sexually transmitted infections on a whole. Gonorrhea and chlamydia in particular can scar the urinary, the genital tract, and cause obstruction of the genital tract and prevent sperm and semen from going into the urethra. Then increased scrotal temperatures. Earlier we spoke about the varicocele, where you have a reversal of blood flow in the veins draining the testicle, and you have these enlarged veins, just like the veins in a man or a woman's leg with varicose veins. And this causes the testicle to be hotter than usual. But men who wear tight underwear, the polyester tight underwear, not good. And men who work in kitchens where you have a constant hot environment, these men may, their fertility may be affected. Then there are endocrine disorders where the testosterone is a very, very important hormone, male hormone that supports normal fertility. If a man has low testosterone levels, it may adversely affect his fertility. And then there are chromosomal and genetic abnormalities. We won't go a lot into those. Immunological factors. There are some men who develop antibodies to their own sperm, especially if they have had injuries to their testicle or operations on the testicle, or if they have this condition where the spermatic cord spontaneously twists and it's not treated in time, they can develop antibodies to their own sperm, because normally these sperm are sequestered from the human blood, and there is what is called the blood-testis barrier. So in trauma, in torsion, where the spermatic cord twists, this barrier is broken down and the man can develop antibodies to his own sperm. In rare cases, women may actually have antibodies to the sperm that attacks the sperm before they can fertilize the egg. And then there are malignancies such as testicular cancers, and the treatment for these, such as chemotherapy, can cause male infertility. Then there are pesticides and other environmental toxins, and very importantly, over the last few decades, globally, sperm count and sperm quality has been declining. And this is thought because of estrogens in the environment. And these estrogens are from plastics, they're from perfumes, they're from deodorants, and these estrogens are thought, they're called selective estrogen receptor modifiers. These estrogens are thought to adversely affect men and their semen quality and their sperm quality. And so these are ubiquitous in the environment. And as I said, over the last couple of decades, we've been seeing a gradual decline in semen quality and sperm numbers. And of course, chemotherapy, radiotherapy, and guess what? The weed, marijuana, all of these can all adversely affect sperm quality. Now, what are the major prognostic factors in male infertility? I mentioned previously the duration of involuntary infertility. That period of time you're having unprotected sex before you have a conception. The longer that period, the worse the prognosis. So if you go in 10 years and you don't have no baby, you don't impregnate a woman, you're in trouble. The age of the female partner, very, very important. At age 35, a woman's fertility takes a precipitous decline. So whenever we are treating a man, whenever we are evaluating a man and deciding on the treatment options, we always take into account the age of the female partner. We will treat very differently, other things being equal, a man who has a partner who is, say, 28 as opposed to a man who has a partner who is 40. Whereas we may fool around and try medications and so on with the man who has a partner who is 28, we more than likely will go straight to assisted reproductive techniques with a man who has a partner who is 40, because our window of opportunity of fertility is very narrow. And as I said, there's a precipitous decline in female fertility in the mid-30s. So that is a very important factor. I mentioned earlier whether it's primary or secondary infertility. Secondary infertility has a much better prognosis than primary infertility. And of course, we look at the results of the semen analysis. All men are sent to do a semen test called a semen analysis, which I'm going to touch on shortly. So we recommend a simultaneous evaluation of the man and the woman because we said 50% of cases of infertility, a male factor is involved. So it doesn't make sense just evaluating the woman first and evaluating the man later. The clinical evaluation, of course, involves a history and physical examination, a semen analysis. It may involve doing hormone tests, and in some cases, a chromosomal and genetic analysis. Now, in the clinical evaluation, we want to know about the period of infertility, whether it's primary or secondary. We want to know the age of the female partner and the outcome of her fertility assessment by her gynecologist. We want to know if there is any male sexual dysfunction. 12% of men who have premature ejaculation, that is, they ejaculate before they want to, they actually ejaculate prior to penetration. So some men who have severe PE are unable to ejaculate in their female partner. So we want to know about sexual dysfunction. Some men may have erectile dysfunction, which we're going to talk about shortly. We want to know about coital frequency. Clearly, if the couples live apart and you're only seeing him once a month, then the coital frequency is not conducive to getting pregnant, okay? Timing of coitus is also important. We want you to focus, you want you to be having coitus when the woman is ovulating, obviously, because that's the time in her cycle when she's most likely to become, encounter conception. We want to know whether there was any developmental delay in the testicles descending, whether there was any trauma or surgery or mumps or any pain, chronic pelvic pain in the genital area, any previous sexually transmitted infections, especially gonorrhea and chlamydia. How many of these you have had? Were they treated right away? Any chronic illnesses, any previous hospitalizations? Have you had chemotherapy or radiotherapy? What medications are you on? Some medications are not friendly to sperm. Whether you drink alcohol or you smoke, especially marijuana, we want to know those things. If you have any headaches or double vision or nausea or vomiting, breast tenderness or enlargement, that may suggest a pituitary gland malfunction, and the pituitary gland is the master gland in the body. If the pituitary is malfunctioning, then you're likely to have infertility. And then we want to know about occupational exposures to gonadotoxins. In other words, things that are toxic to the testicles. Are you a farmer? Do you work with pesticides? Are you a chef? Do you work in a kitchen, etc.? We want to know those things. And then when we look at, we want to look at whether you have what we call male secondary sexual characteristics. You have hair on your face, you're muscular, you have an Adam's apple, do you have hair under your arm, in your genital area? These are things we'll look at. What's the size of the penis, the size of the testicles? These are things we'll look at in terms of determining male secondary sexual characteristics. Body habitus may clue us in on specific conditions, like Klinefelter's disease, which is a chromosomal abnormality. We want to see if there's any stigmata of endocrine dysfunction. For example, some men may have a big gut and big breasts, and that may clue us in that their testosterone level may be low. We want to look at their genital examination. Especially, we want to look at the size of the testicles and what they feel like. If you have small and soft testicles, it means that you have had some previous testicular insult, and that's a very bad prognostic sign. If you have small and firm testicles, that is seen in Klinefelter's syndrome, which we spoke about earlier, and that also is a bad prognostic sign. We want to look if there's evidence of varicocele, so we get the man to stand up and take a deep breath and strain, and you'll see the veins fill out, just like when a woman or a man stands up and their varicose veins fill out. And then, of course, we want to examine the penis, and we want to look at the feared digital rectal examination. We must do a digital rectal examination because prostatitis, inflammation of the prostate, may affect the male fertility. And then we're going to do a semen analysis. And in order to do a semen analysis, the man must abstain from ejaculating 2 to 5 days prior to the semen analysis. It must be done preferably by masturbation, preferably in the lab. And labs are set up to provide privacy. You may have some magazines that men can look at, or if female partner may be there with you to help you. But it's important that it's done at the lab because we need to examine the semen within the hour. Within the hour, because sperm motility declines rapidly. Okay, if it is done elsewhere, it must be delivered to the lab within 1 hour. And we usually look at least 2 semen analyses, preferably 1 month apart. This is what a semen analysis looks like. This is a reference range. I'm not going to spend a lot of time on it because I recognize time is going, but we particularly look at sperm concentration, and 15 million per mil is the cutoff, and we look at sperm motility. Those are the 2 chief things we look at. We also look at morphology, and there are clues that the semen analysis will tell us. For example, you may have a man who has absolutely no sperm in the semen, and that's called azoospermia. And there are obstructive causes for that and non-obstructive causes. All right, if the sperm count is very low, less than 10 million, we're going to check your testosterone level. And if that is abnormal, we're going to repeat it, and we're going to do your luteinizing hormone, which controls testosterone. And we're going to look at prolactin levels, because a prolactinoma or a prolactin secreting tumor is a common cause of that. And that's why we ask about headaches and double vision and nausea and vomiting. So what are the possible diagnoses and their treatment? This is, I believe, is my last slide on infertility. So if it's retrograde ejaculation, then we need to get the man's urine after he ejaculates. But first, we need to alkalinize the urine. So we need to put him on medication to make his urine alkaline, because acidic urine will kill his sperm. And having alkalinized the urine and gotten the man to ejaculate and then collected his urine, we spin it down, we get the semen out, and then we do intrauterine insemination. So we would drop that pellet of semen in the uterus. So that's how we deal with retrograde ejaculation. If there is ejaculatory duct obstruction caused by, very commonly, gonorrhea, then the surgeon, the urologist, will resect the opening of that duct until it's wide open, and that's how we deal with ejaculatory duct obstruction. If there is a varicocele, that is the varicose veins in the testicular veins, and that's causing a low sperm count and low movement of sperm, then we'll fix the varicocele. We'll do what is called a varicocele ligation, and that's a simple surgical operation. If there is mild oligozoospermia, where there's a mild reduction in sperm count, we'll use clomiphene citrate for 6 weeks and then reevaluate the semen in 3 months. The cycle of sperm production is 74 to 90 days. So unlike a woman who has a cycle anywhere from 21 to 28 days, a man's cycle of sperm production is 74 to 90 days. So we would reevaluate the man a minimum of 3 months later. If there is severe reduction in sperm count, or if there's no sperm, then we're going to be doing genetic analysis and possible assisted reproductive techniques. As I said earlier, there's both obstructive and non-obstructive azoospermia, where there's absolutely no sperm in the semen. It could be that the genital tract is obstructed, commonly from gonorrhea, or it could be that there are severe underlying hormonal causes or previous testicular injury or infections that have totally ablated the testicle. Then we'll do a testicular biopsy, see if we can find sperm, do assisted reproductive techniques. If we can't find sperm, then donor insemination or adoption is where we go to. Oh, that was a mouthful. All right, let's take a breather, just for 5 seconds. So we're going to switch gears, and we're going to talk about erectile dysfunction. I don't know how I am for time. Terry Carell, you can tell me if I'm not doing good on time. Okay, I'm good? Okay. So let's talk about erectile dysfunction. But before we talk about erectile dysfunction, let us look at the 5 components of male sexual health. So first of all, there is a motivational desire. There's a motivational component of sexual desire, what we call the libido, or sexual desire. Now, libido, in both men and women, interestingly, is very much related to testosterone levels. And as a man ages, his testosterone level declines. And so one of the things that naturally happens to men as they age is that their inherent and natural and spontaneous sexual desire generally declines. But there are so many variables apart from testosterone that may affect sexual desire. The overall context of the relationship, the emotional support. And female sexual desire is a whole different ballgame than male sexual desire. There's a ton load. There's a book this long of things that affect female sexual desire. But for men, it's not so complicated. You know, it's testosterone, and of course, it's the context of the relationship. And of course, there are psychosocial stressors. Clearly, if you're under financial or job-related stress, you know, the brain is the most important sexual organ by far. And if the brain is under a lot of psychosocial stress, financial stress, if you have exams and so on, you're not going to have much sexual desire. And so it is a truism that the brain is the most important sexual organ. So there's a component, a motivational component of sexual desire, and as I said, that's very much related to testosterone levels. Then there's arousal, and in a man, it's obvious when a man is aroused. The external manifestation of arousal in a man is an erection, right? An erection is what we call a neurovascular event. It depends on intact nerves, it depends on intact blood vessels, and there needs to be a background supporting testosterone levels to support that normal function. But when a man is aroused, it's obvious. He has an erection. Okay, so that's male arousal. Then there is ejaculation, which is a pulsatile, ejectile emission of semen. Okay, so that when semen comes out in a pulsatile, ejectile manner, that's called ejaculation. And typically, that is accompanied by orgasm, which is a subjective sensation of the muscular contractions taking place in the pelvis that occurs at the time of ejaculation, typically. However, let me hasten to add that ejaculation and orgasm are two separate physiological processes. And in fact, there are some men, especially in I hope I'm pronouncing it correctly, Taoist religious societies who believe that ejaculating is not good. They believe in maintaining continence of sperm because they believe when a man ejaculates, it weakens them. They have trained themselves to separate orgasm and ejaculation so they can have multiple orgasms without ejaculating. So it's two separate physiological processes. And then there's an overall satisfaction, sexual satisfaction, which involves components of all of these. Now, before we talk about pathology, we have to look at what is normal. And so before we talk about specifically erectile dysfunction, let me just quickly add what are the normal age-associated changes in male sexual dysfunction. There's no pathology going on here. This is normal. So as men age, there's a gradual decrease in sexual desire. There's a gradual decrease in penile sensitivity. There's a gradual decrease in the rigidity of the erection. So normally, a man's rigidity decreases with age, but he's still able to get a rigid enough erection for penetration. But it may not be as rigid as when he was a 25-year-old, you know, but he can still penetrate. There's less erectile response to psychic stimuli, and this is very important when you prescribe drugs like Viagra, Levitra, and Cialis, because those drugs work in conjunction with sexual stimulation. And for the older man, psychic stimulation is not enough. What he sees, what he smells, or so on. Manual stimulation of the penis is important for the older male because they depend more on reflexogenic erections rather than psychogenic erections. Okay, so there's an increased need for direct stimulation of the penis. There's reduced duration and intensity of orgasm. Boy, age is a bitch, I tell you. There's reduced force of emission and ejaculation. So, you know, when the young boys ejaculate and you see fly over to the next side of the room, when the man gets old, it just barely comes out, you know, and that is the reality of aging. There's a decreased ejaculatory volume. So whereas a young man will ejaculate volumes of semen, an older man will just ejaculate a small amount. And this is a reality. There's a questionable improved ejaculatory control, and this may be related to the decreased penile sensitivity. It's questionable. So whereas young men may ejaculate quickly, an older man may have better ejaculatory control. After ejaculation, unlike a young man where the penis may remain erect for a long time, in the older man, the penis rapidly detumesces, or the erection is rapidly lost. And the final one, the most important one, there is prolongation of the refractory period. And I'm going to explain what the refractory period is, because pharmacists, men will come to you asking for Viagra and thinking that they have erectile dysfunction, and when in fact they don't. So let me explain what the refractory period is. I get a lot of money from men who come and waste their money thinking they have erectile dysfunction when all they have is a prolongation of the refractory period. So the refractory period is that period of time from when a man ejaculates to when he can get an erection. When you're in your 20s and early 30s, that period of time may be 15, 20 minutes. And so you may be accustomed to having sex more than once, 2, 3 times in a night, and so on. What happens to these young men when they hit the mid-30s and the refractory period starts to prolong in the mid-30s? They are in a quandary because all of a sudden they realize that they can't get another erection quite as quickly after they have ejaculated. And they come to me in a panic thinking they have erectile dysfunction, when in fact they don't. All they have is this natural prolongation of the refractory period. A colleague of mine used to say, you know, when you hit your 60s, he was in his 60s, he would say, boy, the sun would rise and set before you could get another erection, compared to a man in his 20s who 15 minutes after ejaculating can get another erection. So this is an important concept because we need to differentiate physiology from pathology. All right, so what is erectile dysfunction? And this is one of the objectives, so defining erectile dysfunction. So erectile dysfunction is defined as the persistent or recurrent inability to either get an erection or maintain an erection sufficient for satisfactory sexual performance. So if the man can't get an erection, or if he can't maintain an erection to the end of satisfactory intercourse, then that is erectile dysfunction. Now, typically this needs to go on for at least 3 months for us to define it as erectile dysfunction, because we recognize that men, as I said earlier, the brain is the most important sexual organ. If a man is grieving, if a man is suffering from financial stress, if a man is under significant psychosocial stress, he may have periods where he naturally just doesn't want to perform. He doesn't feel like having sex. And this is why we use that 3-month period. But there are some conditions, men who have had surgery, men who have been in motor vehicle accidents, where we don't apply that 3-month period because those things may be suddenly associated with the inability to get an erection, okay? Now, erectile dysfunction has a major negative impact on the quality of life. You will see from this study where premature ejaculation was given a reference value of 1, that erectile dysfunction is has a 5 times greater impact on negative quality of life, followed by low sexual desire. So you see that erectile dysfunction is a significant factor affecting men's quality of life. A man's ability to get an erection is tied up with his whole sense of manhood and selfhood. And so when a man suffers erectile dysfunction, it's a significant problem for him. What is the prevalence of ED? How many persons in the community have erectile dysfunction? So many studies have repeatedly shown that men between the ages of 40 to 70 years old, that 52% of men have some degree of erectile dysfunction, whether it's mild, moderate, or severe. So more than 50% of men, believe it or not, age 40 to 70 years of age, using the definition that we had earlier, have some degree of erectile dysfunction. Now, before we talk about how erectile dysfunction comes about, let's look at the normal penile anatomy. Unfortunately, I don't have a pointer here, but if you were to cut the penis in cross-section, there are 3 bundles in the penis. So if you do about Babette, Babette who cut off her, so if you do a bobectomy on the penis and look at it in cross-section, you see 3 bundles. The two bundles on the top and at the side are the erectile tissues, what we call the corpora cavernosa. And these contain the spongy erectile tissues that when a man is sexually stimulated and aroused, the smooth muscle in these vascular sinusoids or blood lakes, they relax and allow them to fill with blood. The blood vessels supplying those sinusoids relax and dilate. And as the sinusoids dilate and the vessels dilate and bring more blood into the penis, the veins leaving the penis are squashed, and so blood is prevented from leaving the penis. So you have increased blood flow into the penis, while at the same time you have decreased blood flow out of the penis. And all three of these things have to happen for you to have a full, rigid, turgid erection. All right, now when we look at the underlying chemical, the underlying chemistry of erections, when a man is sexually stimulated, whether psychically or whether by manual stimulation of the penis, the nerves supplying the penis release what is called nitric oxide, as well as the vascular sinusoids within the penis. They release this very important chemical called nitric oxide. Interestingly, men, you can get nitric oxide from drinking beetroot juice, right? Beetroot juice, it is said that Hugh Hefner's secret was that he drank a lot of beetroot juice. Anyway, that's just a tidbit. So nitric oxide is this very, very, very important chemical that interacts with this enzyme called guanylate cyclase that converts GTP to cyclic GMP. And it is this cyclic GMP in the smooth muscle cells that acts on cyclic GMP-dependent protein kinases that causes a sequestration of calcium within the cell, and calcium is pumped out of the cell. Calcium is prevented from coming into the cell. So the cell experiences a low intracellular calcium level, and we know calcium is necessary for muscular contraction. So when the calcium levels decline in the cell relaxes, blood flow increases into the penis, the sinusoids expand and compress the veins, and you get a full erection. Now, there is this very, very important enzyme called phosphodiesterase E type 5 that breaks down the cyclic GMP. And this is what Viagra, Levitra, and Cialis act on. It inhibits this enzyme called phosphodiesterase type 5 that breaks down the cyclic GMP. And herein lies the importance of why these drugs will not work if the man is not simultaneously sexually stimulated, because you have to generate cyclic GMP for the inhibition of the phosphodiesterase type 5 enzyme to work. If you're not generating cyclic GMP, so if the man takes a Viagra, the Levitra, or the Cialis, or one of the generics to it, and he's not sexually stimulated, not a thing is going to happen. He must be told by his doctors and his pharmacists that he must be sexually stimulated. And for the older man, we heard earlier that the sexual stimulation must be manual. It can't be just the wife or the girlfriend or whatever in just sexy lingerie. It has to be manual stimulation or oral stimulation, whatever, but it has to be manual. The penis has to be stimulated. So we heard earlier that there are two broad categories of erections: the psychogenic erections based on fantasies, based on sight, and so on. And then there's the direct stimulation of the penis that results in reflexogenic erections. And in reality, both are important. So causes of erectile dysfunction. Very quickly, they are broken down into psychological causes and organic causes or physical causes, and then there are mixed causes. In reality, 85% of cases of the initial cause of erectile dysfunction is due to organic causes, not psychological causes. That's important to remember. You're going to have a test. So organic causes, the most of the causes of erectile dysfunction are due to physical or underlying organic causes. But guess what? There is what is called performance anxiety. which is an overlay that perpetuates erectile dysfunction. So when a man fails to get an erection, on a subsequent occasion, he's going to be wondering whether he'll be able to get an erection. And this causes anxiety. And when the body experiences anxiety, certain chemicals are released, certain hormones are released. Adrenaline, the fight or flight response, which is the natural response to anxiety. And these chemicals shut an erection down because they cause the blood vessels to constrict. So whereas organic causes are the major causes of ED, psychological causes such as performance anxiety tend to perpetuate them. The major cause of erectile dysfunction on the organic is vasculogenic causes. So narrowing of the blood vessels, or what we call veno-occlusive dysfunction, where you lose blood from the penis. And then there are neurological causes, endocrine causes such as diabetes, for example, end organ failure such as men with sickle cell disease, who have what we call priapism, where they have a prolonged painful erection and they get scarring in the penis, or Peyronie's disease, where they have scarring in the penis and the penis bends, has a bend in it that prevents it from becoming fully erect. And then there are many drugs, including drugs to treat hypertension, drugs to treat prostate cancer, that may cause erectile dysfunction. This is a list of risk factors. Age per se is not a cause of erectile dysfunction, but the factors, the lifestyle, the poor lifestyle that goes with age. So the sedentary lifestyle, the bad eating habits, all of these called atherosclerosis, which narrows the blood vessels, the lack of physical exercise, obesity, stress, diabetes, hypertension, cigarette smoking, all of these, high cholesterol levels, all of these are causes, are risk factors for erectile dysfunction. So when we look at this particular slide, this shows the pathophysiology of vascular ED, which is the most common cause of erectile dysfunction. So things like hypertension, diabetes, high cholesterol levels, they cause structural changes, a narrowing of the blood vessels called atherosclerosis. So because the blood vessels are narrowed, the blood flow into the penis is diminished. And importantly, and I'm going to emphasize this point again later, it's not just the penis affected. It's the blood vessels to the heart, the blood vessels to the kidney, the blood vessels to the brain. And I can't overemphasize this point. If you don't remember anything else, remember this. Severe erectile dysfunction is a biomarker for heart attack, stroke, and kidney disease. So this is why it is a disservice when a man has severe ED and you just give him a Viagra tablet and so on, and you don't evaluate him for all of these things. Anyway, so the narrowed blood vessels cause a decreased inflow of blood to the penis. The reduced blood flow to the penis causes the smooth muscle in the penis to atrophy or degenerate. And so they don't function well, and so the penis leaks blood. So there's a decreased inflow of blood to the penis, and the penis is also leaking blood. So you cannot get a rigid erection. But from a functional point of view now, things like the hypertension, the diabetes, that causes what we call reactive oxygen species. In other words, you get this damage to the blood vessels by these reactive oxygen species that causes a reduction in the generation of nitric oxide. We saw how important nitric oxide was, and that again causes impaired relaxation of the penis. It causes impaired relaxation of the trabecular muscles, and you get the leaking of blood from the penis as well as the decreased inflow. So this is just a slide to wake you up, and it shows the importance of the performance anxiety. It says, Lord, please, I beg you, please make thy servant rise to the occasion. And it's a serious thing, because once a man has experienced erectile dysfunction, it's always in the back of his mind when he's with his partner, whether he's going to have that problem. Now, it is your responsibility as pharmacists and doctors to ask patients whether they have erectile dysfunction. It is not a taboo subject. Patients will not broach it because they are shy, less so now than before, less so now than before. But if if patients don't raise this issue, it is your responsibility to ask them if they are suffering from erectile dysfunction. And many times a patient will come into your office and tell you about all kind of things when it's really that them really want to talk about, you know? So it's important to raise that issue. Why is my slide not okay? All right, so in the interest of time, how do we evaluate this? We take a detailed history, we do a detailed examination, and that includes sexual, medical, psychosocial history. We apply some instruments, and of course, we're going to examine the genitalia and the penis. In the terms of the sexual history, we want to know exactly what the problem the patient is having, how long, did it occur suddenly? If it occurs suddenly, it is a psychological problem usually. If it is of gradual onset, it tends to imply an organic cause. Is it progressive or is it static? For men who have multiple partners, sometimes the problem is only with one partner and not with all partners, and you know right away that's a psychological problem. Are there early morning or nighttime erections? If the man is having early morning and nighttime erections that are rigid, but he can't have an erection with his partner, that's a psychological problem. Interestingly, early morning and nighttime erections are important because they signify adequacy of testosterone. Okay? Is the problem lifelong or is it acquired? And how does the patient rate his sexual desire? So these are important questions. Then you can ask the man about his erection hardness. Is the penis larger but not hard? Is it hard but not hard enough for penetration? Is it hard enough for penetration but not completely hard? And 4, is it completely hard and fully rigid? That's known as the erection hardness score. And then we take this, what we call sexual health inventory for men, which in the interest of time we're not going to go through, but the maximum score is 25, the minimum score is 0. Anything below 21, there's some degree of erectile dysfunction. Then we're going to ask about diabetes, cigarette smoking, obesity, lifestyle, diet, hypertension, and the treatment of these things, because the medications the patient is on, because all of these things may affect a man's erection. Okay, we're going to test his urine, we're going to check his blood sugar, we're going to look for high cholesterol, we're going to check his testosterone, we're going to check for prostate cancer if he's over 40, and we're going to do hormone studies. Now, how do we treat erectile dysfunction? So we're on the last couple of slides now. I know we're probably over time. But it's important, as I said earlier, that when men come to us with erectile dysfunction, we don't just simply give them Viagra, Levitra, or Cialis. We have to take a detailed medical history and determine what are the factors at play here. If the man is smoking, we need to get him to stop smoking. If he's not exercising, we need to get him to start exercising after a cardiac evaluation. If he's overweight and obese, we need to give him dietary advice or send him to a nutritionist who we had on the program earlier. All of these things are important. We need to alter modifiable risk factors. Remember, severe ED, the man maybe about to have a heart attack in another year or so, and it's a good thing he came to you with this problem, because you can now change a natural history. If you just give him a Viagra tablet, then you're not doing him any service. Okay? So having identified these modifiable risk factors and change the trajectory of them by altering them, then the next step is giving oral agents, and these are Viagra, Levitra, Cialis, and their generics. Okay? And it's important when you're prescribing these to tell the man that he must be sexually stimulated when he takes it, because if he takes a tablet and he's not sexually stimulated, and nothing going to happen, right? If the ED, if the erectile dysfunction is still unresolved, then local therapies. Years ago, we used to have what was called Muse, where you could instill a pellet of prostaglandin E1 in the penis, and that would give you an erection. But that went off our market. Plus, men never like it. They never like to insert anything in the penis. And then the other thing is, if a woman was pregnant, it would cause problems and sometimes burning. But you can inject the penis. You can give what is called intracavernosal injections, very, very effective. You can give what is called a vacuum erection device. You put a vacuum over the penis. You create a vacuum. You put a tube over, a cylinder over the penis. You create a vacuum, and that pulls blood into the penis, and you put a constricting band at the base, and you can use it for half an hour. But again, it's cumbersome, and a lot of men don't like it. And if you have If you have any bleeding tendencies or sickle cell disease, you can't use that method. And if you're still having erectile dysfunction after that, you can always get a penile implant. And we can implant a penile prosthesis, and that gives you a very satisfactory outcome. All right? So these are the treatment options. The PDE5 inhibitors like sildenafil, tadalafil, and vardenafil. We spoke about the intraurethral prostaglandin E1, Muse, the vacuum erection device, intracavernosal injections directly in the penis. You can use a combination of drugs, injecting the penis, what we call trimix. For those men who have low testosterone levels, you replace testosterone. And then if all else fails, you can surgically implant a multi-component inflatable penile prosthesis. So this is just showing the various things that you can do. And again, we show how Viagra, Levitra, and Cialis acts. It acts by inhibiting that very important enzyme, phosphodiesterase type 5. And can't overemphasize that the man needs to be sexually stimulated to generate cyclic GMP. And then, of course, we must not forget the female partner in all of this. The female partner is very, very important because sometimes women will avoid initiating sexual activity or avoid approaching the man because they don't want to embarrass them. So it is good to have the female partner on that journey with the man to improve his erectile function and to know what is happening and to support him. And so I want to end this talk by focusing on the important role of the female partner. Of course, sometimes in Jamaica that might be a problem because men may have multiple partners, but that's a time for another story. Thank you very much for your attention. Okay. Thank you.
Thank you so very much, Dr. Aiken. Come on over. I see a lot of persons smiling and laughing on my screen. That was a pretty comprehensive, I mean, it's a huge topic, and it wasn't just one. It had two, and the fact that you were even able to put this in some way, shape, or form that we could digest it and understand and have takeaways is actually quite impressive, and we do appreciate the tidbits and the laughter that you added in there as well. Now, we did two polls during your presentation, and the first one was, which is more important to the Jamaican man? Is it long and strong, thick and quick, or short and spicy? Well, long and strong came out on top with 93%. This is what our attendees think is most important to the Jamaican man.
Are these mostly women?
These are mostly women, I believe. These are mostly women, and I see them laughing there on my screens. And so long and strong was 93%, short and spicy was 4%, and thick and quick was 3%. The second poll question was, which one of the following is most popular amongst Jamaican men? Horse tonic, roots drink with maca maca, something really good, sir? Maca maca, strong back, molasses, baba roots, or is that I've never pronounced this properly. Sarsaparilla. And the one that came out on top was 61% was strong back. At some point in time, we have heard persons speak about it. This is a very, not just a big topic, but it's a sensitive topic. And before I introduced you, I said a lot of the time, the shame, the invasion, and the intrusion of body happens to the female. Right. It's almost never the men. And there's some men, thankfully, who have come to terms and can walk with their female partners through this, and there are others who can be abusive, even though it's not the female's problem. Talk to me about, and you certainly busted a lot of myths. Tight pants are part of the culture. We even had our nutritionist speak about culture, what we're accustomed to, the food we see our parents eat. Tight pants, which is a part of our pop culture. It's a fashion, it's a lifestyle. True or not true, just like the tight underwear that you spoke of, this could impact men's performance or the ability to have erections.
Absolutely, Terry Carroll, absolutely. Because if you chronically wear tight pants, if you wear tight pants all the time over a long period, then the scrotum is going to be kept hotter than it should be. Because, you know, the scrotum is apart from the body for a purpose. The testicles or seeds need to be kept cooler than the rest of the body. So if you're wearing tight clothes continually, then it's going to adversely affect your sperm production, especially polyester, things that don't allow the genital area to breathe. And this is bad for both men and women. Women will get yeast infections, and because of the wet moistness, of that area, yeast infections are more common in women. Well, in men, it will affect your sperm production.
All right, so when we tell men, tight pants is not necessarily it. It's not that we're being haters. It's not that we're trying to be subjective when it comes to fashion, but because there is a health consequence, a health risk as well. So we have one of our attendees, Anonymous, who asks, what is the difference between orgasm and ejaculation? Is it related to the production of semen? I remember you in your presentation stating that they are two different things. Ejaculation has to do with the emission, whereas or the orgasm is subjective, you said, depending on the man. Would you like to expose?
So there are actually two separate physiological procedures. So in ejaculation refers to the projectile release, and it's usually propulsive release of semen. That's what ejaculation is. And what happens there are muscles rhythmically contracting that allows that to happen. The bladder neck closes, what we call the external sphincter opens, the muscles around the urethra rhythmically contract, and the semen comes out in this projectile, pulsatile manner. And that is what is known as ejaculation. Orgasm is the subjective awareness of the feelings generated by that muscular contractions. So it's a highly pleasurable experience that's experienced up in the brain from the muscles contracting in the pelvis. Now, some men can experience these muscular contractions without actually ejaculating, and so they can experience multiple orgasms. And as I was mentioning, the Taoists have trained themselves to control their ejaculation to the point, because they believe that ejaculating weakens a man. So they have trained themselves to experience sexual pleasure through orgasm without actually ejaculating. So there are two completely separate physiological processes.
And does it have anything or any relation to the production of semen, which was the second part of the question?
Well, okay, so that's an important question. So a man can actually ejaculate and very little semen or no semen comes out. For example, there are some drugs that we treat men with for an enlarged prostate. Drugs such as tamsulosin, drugs such as dutasteride, finasteride. So tamsulosin causes relaxation of the bladder neck and the muscles in the genital area and the prostatic muscle. And that can actually cause semen to go back into the bladder. But the man still experiences the sensations associated with ejaculation. But it's funny because in our society, most men, ejaculation and orgasm occur simultaneously. Okay, but you can, for example, a man who has had a radical prostatectomy for prostate cancer, where we completely remove the prostate and we tie off the vas deferens, they still experience all the sensations associated with orgasm, but they don't ejaculate because there's nothing to ejaculate. Their vas deferens has been tied off. 70% of the semen comes from the seminal vesicle. So if your vas deferens is tied off, and your prostate, where 20% to 25% of your semen is produced from, has been removed, there's really nothing to ejaculate.
Right.
So, but they do experience the subjective sensations of orgasm.
Okay, our next attendee, Anonymous, asks, is the size of a man's belly a negative influence on his ability to have an erection?
Absolutely, absolutely. So let me speak to that. So when a man has a big belly, it's usually due to a subcutaneous laydown of fat. When a man has a large, what we call centripetal obesity, or a large component of fat around his abdomen and around the intestines, it actually acts as another organ, an additional organ in the body that impairs the pituitary gland, that it impairs the production of luteinizing hormone, which in turn regulates the production of testosterone. Not only that, but fat converts testosterone to estrogen. So a man who has a large belly is producing more female hormones, and he's impairing his pituitary gland, and these men very frequently develop what is called hypogonadism.
Yes.
They develop a low testosterone level, but they also develop what is known as metabolic syndrome, where they develop hypertension. They may develop insulin resistance and actually become diabetic, because there is a whole series of hormones being released by the fat, and these are pro-inflammatory, and they impair the health of the blood vessels. So absolutely, yes, a man with a big gut or big belly is definitely at risk of having erectile dysfunction.
And I think it goes back to culture again, where we think that, these things are fine. The bigger the person, the better life is, it's a life treating you well, and we tend to say that because, it shows.
Yeah.
But certainly these have to be normalized conversations, which is really what MDS is trying to have, these uncomfortable conversations sometimes, but that leads to transformation. Shanique Clark Brown, very good question. She asks, can Viagra, Cialis, Levitra contribute to ED if young men who do not have ED use them to last longer? So here it is, you spoke about it sometimes. You have men who don't have ED but have self-diagnosed, and they're now being given these drugs. Can they, in fact, develop the real thing?
That's a very good question. A lot of young men use these drugs to shorten the refractory period. We spoke about the refractory period earlier. Well, one of the off-label uses of this drug by young men is to shorten that refractory period to allow them to have intercourse multiple times in a short period of time. There is no known tachyphylaxis, and the pharmacist will understand that term. So there is no withdrawal associated with these drugs. In other words, there is no dependence on them. In that, there is no situation where your body becomes accustomed to these drugs, and when you withdraw from them, you have a problem.
Right.
And that's called tachyphylaxis. So there is no known tachyphylaxis. So the answer is no. The short answer is no.
Okay, and by the way, Doc, this is a very hot topic because I have more questions. So Kristen Grenyon says, how important is masturbation in penile health? And the second, she has a two-part question. Can blue balls affect penile function?
All right, so let me take the second question first. So blue balls is a situation where a man is in a prolonged situation where he's significantly sexually aroused, but no orgasmic release takes place. So young couples, heavy petting for prolonged periods because of the vascular engorgement of the testicles and the genital organs. The man experiences severe pain in the pelvis and in the testicles in particular. No, the answer is no. If there was, then almost every guy every guy would develop problems with his penis, because all of us, during young adulthood and teenage years,
at some point in time experience
blue balls. So the answer is no. Masturbation is a normal human activity, and I'm not aware of any adverse effect that masturbation has on penile health. What I will say is that there are some men who become addicted to it, and it affects their normal functioning. So if you are at a point where you prefer to masturbate than to be with your partner, then that's a problem. If it's affecting your normal functioning, if affecting your job, affecting your relationships, then that's a problem. So, but no, there is no adverse effect of masturbation on penile health, except that some men have very weird and unusual masturbatory techniques. I've seen where men have come into hospital with a tight ring around the penis that we had to put them to sleep and take a saw and remove it. There are men who
saw and remove what?
The metal ring.
The ring, okay.
The metal ring.
Okay.
There are some men who have put their penis in a vacuum vacuum cleaner and have
ended up with the skin of the penis being avulsed. So outside of those weird and unusual masturbatory techniques, normal, healthy masturbation doesn't have any adverse effect on penile health.
By the way, Doc, as you were mentioning that, I saw a number of women laughing there. And because the screens are so far, I can't see the gentleman in the blue, but he was just like, listen here, I don't know what those men were thinking. I can see your reactions. I absolutely can. Vacuums, I had no idea. Melissa Campbell Foster, Greater Portmore Pharmacy says, what condition is ED a marker for?
Okay, so it's a
question.
It's a marker for ischemic heart disease or coronary artery disease. So remember we said a normal erection is a neurovascular event. So for an erection, a normal erection to take place, your blood vessels must be in a good state of health. The most common cause of erectile dysfunction is a narrowing of those blood vessels, a process called atherosclerosis. And this is caused by obesity, diabetes, sedentary lifestyle, lack of physical activity, hypertension, hypercholesterolemia, prolonged stress. So these are the risk factors, cigarette smoking. So if a man has narrowed blood vessels into the penis causing severe erectile dysfunction, this same process is going on in the heart, in the kidneys, in the brain. And so this man is at risk of ischemic heart disease and ending up with angina, acute myocardial infarctions or heart attacks. They're at risk of kidney failure and they're at risk of strokes.
Wow. And again, it goes back to the lifestyle.
Absolutely.
Nutrition and everything has an effect on it. So I have three more questions, and then we'll call it a wrap. I have a question here from Intrula Brissett Foreman, a freelancer. And she asks, recommendation for prolonged erection due to Trimix?
Okay, so Trimix is one of the drugs we mentioned earlier. It's actually a mixture of 3 drugs that is injected directly in the penis. It's called an intracavernosal injection, and it's used in men in whom the oral agents have not worked. And so the next step is to try either the vacuum erection device or intracavernosal injections. You may use one agent like prostaglandin E1, or you may use a combination of agents in Trimix. Trimix is 3 agents that all act independently to increase the blood flow in the penis. Now, very importantly, when a doctor is initiating treatment with Trimix, it is very, very important that he starts out at a very small dose, and the dose he starts out will be dependent on the underlying factors that is causing the erectile dysfunction. If it's a young man who may have some psychogenic ED, then you want to use a very, very tiny dose. Or if it's a nerve problem, very tiny dose. If it's a long-standing diabetic, refractory diabetic, then you need a bigger dose. But it's very, very important to determine the correct dose, because you don't want the erection lasting for more than an hour or 2. If the erection lasts for more than that, then the man develops a prolonged, usually painful erection, which is known as priapism. And if the man develops priapism, then that actually shuts off the blood flow into the penis, and the penis becomes ischemic, and the tissues of the penis will die, and the penis will be replaced with scar tissue.
Wow.
So it's very important to determine the timing and the dose of drugs like Trimix when we're prescribing them. Absolutely.
And it just sounds so flippant when you hear them speaking about the use of drugs and how they feel. You know, it seems so flippant, and yet still it is a science, it appears. Saskia Monroe Solomon, will stopping heavy ganja use, you spoke about marijuana being one of the elements on the list or factors that could put men at risk. She says, or she asks, will stopping heavy ganja use reverse the damage or infertility, or is that permanent? So she wants to know, can it be reversed?
It's not permanent. It's not permanent. Certainly stopping marijuana use after a period of time will result in improvement in the seminal parameters. So the sperm count and the movement of the sperm will increase. Remember, the cycle of sperm production is 3 months, 74 to 90 days. So after stopping marijuana use, you may need several cycles of sperm production before you see an improvement in the seminal parameters.
Right. Our final question comes from Kristen Grenion, also a freelancer, and she says, if a man practices abstinence for a long period of time, is that an advantage or disadvantage with future performance / fertility? If that can even be answered. Sounds subjective.
Yeah, I'm not aware of any study that suggests that practicing abstinence adversely affects the male reproductive system in any way, shape, or form. What I will say is that there are studies, pretty robust studies, that suggest that the more frequently a man ejaculates, especially early in his life, in his 20s and so on, the less likely he is to develop prostate cancer later on. Pretty robust studies. Also, we know that the whole sex is a very important part of life. It's sex when a couple engages in sexual intercourse and sexual relations, there is release of endorphins. It's very important for your mental, psychic health, your immunological health. And so sex is an important part of life. And I would imagine there are some studies that suggest, and it may not necessarily be related to sex itself, but persons who are isolated and alone, they suffer much higher risk of sudden death and health issues compared to persons who are in a loving community.
Companionship.
Correct. So especially in this coronavirus time, we, you know, a lot of people, older people dropping out suddenly, people who were in fairly good health, you have to wonder, is it the social isolation, the lack of companionship and so on that has took an effect on them?
Thank you. Dr. William Aiken, I'm sure, I mean, you saw the amount of questions that came in, which meant that as even though your presentation was comprehensive and it certainly covered a lot, people were engaged and they were listening and they were asking their questions. And certainly my colleagues here at Phase 3 Production, they've done so many events and I've never seen them as attentive as during this particular presentation, which means that, sir, you have hit the spot. And in all honesty, we want men in Jamaica to become more comfortable with their bodies in a very meaningful way, manner, not just the long back, strong back,
in a wholesome way,
but in a wholesome way. With the same amount of energy that women put into it. I think that is what we're trying to drive here.
Absolutely.
And I thank you so very much for your time and your brain. It's amazing. Thank you so very much, Dr. Aiken.